Hello, everybody. This is Mark Lynn with Healthcare Business Specialist in Chattanooga, Tennessee. Welcome to our pop-up webinar on telehealth Medicare Part B billing, not rural health clinic, and non RHC time. We put this webinar together because we knew we have a lot of information to cover on our scheduled RHC webinar coming up as soon as the RHC regulations are released. I knew I wasn't going to have enough time to get through all the Part B material. So I'm going to go ahead and record this for you ahead of time so that when I run out of time, when we do the real webinar, you will at least have this one to fall back on. We want to thank our sponsors, Zelia Health and ChartSpan for helping us put these things together and sponsoring us. There's my picture and there's my information if you need to get a hold of me and ask questions. If we do get something wrong, which we probably will, it's a lot of material, a lot of it's brand new. Sometimes it contradicts what happened a few days ago. Sometimes CMS contradicts something they did and has to go back and correct things. So things are moving very quickly. We're in what we call COVID-19 time, which is accelerated from what anything we've ever seen. So I do apologize if there are errors or omissions in here. We have 90 something slides. I keep trying to pare this thing down and try to make it very brief, and failed miserably on that. And hopefully it will not be too confusing. There's going to be a lot, it's going to be sort of like a bad movie where there's a lot of flashbacks and flash forwards and histories and flash sideways. And so it will be very hard to make this something that's very easy to understand. And I apologize for that. There's Danny Gilbert who works with us. She's been doing the majority of the work behind the scenes, preparing Medicare cost reports and keeping those going in her TennCare quarterly reports. So please feel free to reach out to both Danny and myself at any time during this COVID-19 pandemic. We're extremely happy to help you. It really doesn't feel any different to us than any other time because we're both locked in this time of year doing cost reports. It just feels weird that I'm not doing cost reports 16 hours a day and working on COVID-19 16 hours a day. If you're not a member of our Facebook group, please join. We have we're closing in on 1,500 members here, so please join. It's grown from 850 just recently. There is a ton of great information on there. So several great consultants that are helping out with this, and they are really providing a great service, answering questions very quickly, questions that I couldn't answer. So we appreciate all those people that are working to make that work for you guys. Here is what we do right now. We're just in the middle of cost report season, so we're preparing lots and lots of cost reports and working, trying to keep you guys afloat during COVID-19. Here's where all of our resources are, so you can go in there and the presentation will be posted there. It'll also be posted on YouTube. Our slide presentation will be on there as well, and we do update this website pretty much every day, maybe not quite every day lately, but we try to keep it updated pretty much every day. Disclaimer, again, with all that's going on here, everything is rapidly changing. Guidance is backdated from CMS. They will issue something one day and then retract it the next. Official documents that you will see, a lot of times, they will be out of date almost as soon as they're issued. And so I've tried to notice some of those that has out of date information there. So I put a little caution, out of service, on there. So if you see that, that means that all the information is not quite up to date, but the problem is everything is changing very rapidly. This presentation was being performed on Saturday, April 11th, 2020. As far as I know, it's current as of today, but again, I could have missed something. If you see something wrong with it, let us know. We'll be glad to correct it. We may re-record it if we mess it up really, really badly. So let's go into the content of today's webinar. It's going to be over telehealth. It's going to be over Medicare Part B fee-for-service. One more time, not about rural health clinic. It's about Medicare Part B fee-for-service, or if you have non-rural health clinic time. Telehealth is definitely changing the way healthcare is delivered. I've got my first telehealth appointment with my cardiologist in a couple of weeks, and and it's really changed things very rapidly. You can see how we're evolving to where telemedicine hopefully will be the standard in the future, and if CMS will relieve the burden of the originating sites, that's really slowed down telehealth. And we'll tell you what an originating site here is in a minute. But this could be the best thing that ever happened to healthcare, is getting telehealth, because COVID-19 is really speeding the pace which telehealth is being adapted. We will talk about Medicare rules. People get confused all the time. They're saying, oh, we're a rural health clinic, that means we can't do telehealth. The answer to that is no. It's just because Medicare, don't let the tail wag the dog. Medicare patients are old like me. They don't really want to be doing telehealth visits. They don't really do that well with technology. I don't do that well with technology. And so don't let those Medicare patients that are only represent about 20 to 25% of most physician practices, most rural health clinics that we deal with, don't let that tail wag the dog. We always tell people, follow the golden rule. He who has the gold makes the rules. Insurance companies are out there paying telehealth. They understand it. They want to use it, and they have very good payer rules. There's parity rules throughout the country. And the Center for Connected Health Policy is fantastic. They have lots of information, lots of webinars out there. The executive director, she is fantastic. So we'll have a bunch of links to them in a minute. Do keep up with your insurance guidelines. Here's the different ones from Tennessee. Here's Aetna, Cigna, United, Humana. Click into that resource there, and you will be able to find how those insurance companies pay. That's going to be very important. Also, create a cheat sheet. Here's a couple of cheat sheets, which I did not create. They're Excel spreadsheets, but they're basically showing how you bill certain insurance companies. So create your own Excel spreadsheet, and you can click into these. These will give you a really good head start, but you'll want to double check these and make sure that they're what your insurance companies are paying, but they're a great start for you guys. Here is the status of all of the different reimbursement rules from the Center for Connected Health Policy. If you just click on the state that you're in, it'll bring up whatever your policies are currently in your state. So it's a fantastic resource. We are currently in what's called an 1135 public health emergency. You'll hear me refer to PHE. You'll see PHE, that stands for public health emergency. A lot of rules, a lot of waivers are taking place during the period of time of this PHE. It doesn't mean that things are going to be this way forever, but until the public health emergency, I think it goes back to March the 1st, is when it is actually declared. March the 6th or 7th or 8th or so. It was a different day, but it's one of those things that was backdated. It's backdated to March the 1st, the official day. Maybe it's March 17th. But here is some of the things from the Center for Connected Health Policy, and a couple of webinars that they've just done recently that are fantastic. The first one over here on the right hand side is out of some of it is definitely out of date by now, but again, a really good resource for getting state information for you guys there. And then there's an actual spreadsheet that they've done giving you information about each state at a quick. It's like a 5-pager. It's excellent. Also, if you want to know about your laws about crossing state lines, a lot of that has been waived from a Medicare standpoint, but you still have licensure issues. If you're, I live in Chattanooga, Tennessee, so we've got Georgia, we've got Alabama, we've got North Carolina, we got South Carolina that's relatively close as well. I mean, so we have a lot of states that are relatively close to us. And if you're doing telehealth in Chattanooga and your patient is located in Georgia, you're crossing the state line. So you need to be, typically you would need to be licensed in Georgia unless Georgia's waived it, which they're a green state, which apparently that means that they have waived that. So we can do healthcare across the line without worrying about it. But you want to check that and make sure that you're okay. Also check your malpractice insurance and make sure that telehealth is covered under your malpractice insurance if you are starting a telehealth program. So it is a race. This is not a marathon. This is a sprint to get up and going. Before I did a webinar with Azalea back in October, telling people that telehealth was coming. I had no idea that this tsunami pandemic was going to bring it as fast as it has, but it is definitely here. And to get your program up and going, one of the first things you want to do is find a good toolkit. And there's tons of good toolkits out here. Probably the one most applicable to our clientele, because we work with rural health clinics, is the rural telehealth toolkit here. And if you click on the link, and when you get the slides, all these are hyperlinks, so that will take you right to this. It's divided up into about 6 or 7 different modules there that you can go through from the RHI hub, and they do a great job keeping rural health providers up to date with information there. They're very gracious about putting our seminars and webinars on their website when we have those. So we have lots of handouts from them too. So when you come to our webinar or seminars, we will hand you RHI hub stuff as well. So we appreciate them helping sponsor us. CMS put out a toolkit back in, and I'm losing track of all my dates here. It was very early on, maybe March 6th or 7th, about doing telehealth. It is out of date already, so it says a little caution, out of service on here, but most of the information, this little box here, is definitely out of date. So you want to, when you use that table, it will not be up to date, but it's a great starting point for you. And then the American Academy of Family Physicians or practitioners, or one of those, they have a really good toolkit as well. If you Google telehealth toolkit, you're going to find 10 great ones, things that much better than I could ever do. Also, you got to think about your workflow. Do a practice telehealth visit with one of your staff before you get started, and set up your process and think about what will happen. And it goes through this visual thing here from BMJ is really good. Tells a sort of, to think about what you're going to do before you actually have one, and maybe put together a script on what you want to say and how to get started. And then once you do a few of them, it'll be like sort of like riding a bicycle, But I think the first few of them will probably be a little bit rough. You'll learn a lot of things about how to do them. I know from talking to providers, you have to use different senses than you normally do. It's a lot more visual. You have to look at that patient a lot more because you can't feel, you can't touch that patient. You don't have the vital signs that you have before, but so it's a lot of visual cues that you learn to pick up in doing those types of visits. The secret to creativity is knowing how to hide your sources. We will not attempt to hide our sources here. We are going to try to give you all of where we captured all this information, and basically put it in a format so you guys can digest it easier than I did. But believe me, as hard as this is for you guys to digest, it was much harder for me. I've been working on this thing for 2 to 3 weeks now, and finally just said, we've got to get something out on telehealth now before it gets too late for everybody. And so what we've done, we put together a sortable database. It's in Excel, and basically all of the different CMS memorandums, the waivers, the webinars, anything related to COVID-19 that's come out recently. We've put it together, 75 different links on there. So if you know there's something out there that you can't find, this is a really good way to find that. And if you are a rural health clinic, go into the NARHC and do that survey. There's lots of more money coming out. There's about $70 billion more of a $100 billion fund that should be coming out. And then there's also phase 4 of the legislature that's coming out, and they're going to have some rules as well for getting additional monies to rural health clinics. So fill out that Survey Monkey survey from the National Association of Rural Health Clinics. That will help you guys get more and more resources to survive this. Go back in time? Of course we can. That's a quote from The Great Gatsby. And CMS has figured out a way to go back in time because they've been backdating a lot of information. So look at the information closely and see, you may have to actually go back and refile some claims. I know the CS modifier dates back to March 18th, and we'll show you what the CS modifier is in a minute or two. Here is the first big notice that CMS was expanding telehealth during the period of the PHE, the public health emergency. That came out on March the 17th. And then there is the newsroom fact sheet that came out during that. I won't read that to you, but that's a resource for you. Some of the key takeaways was that effective March the 6th, 2020, Medicare will make payments furnished to patients in broader circumstances. And it basically did away with originating sites. And we'll talk about what originating site is. Again, remember when I said we're going to be going, it's like a bad movie where you flash forward and flash back and flash sideways. We'll have a lot of that as we go through these slides here. But they did away with originating sites, and that's something very, very important. They also will pay visits. They pay telemedicine as in-person visits at the regular in-person rates, and we'll show you how important that is for you guys as well. So a couple other key takeaways is copays and deductibles. If you don't collect those, then the Office of Inspector General is not going to be coming after you. Waivers on HIPAA as well. They're actually not waiving the rules, but they're not going to enforce them during this time. So there's a couple of HIPAA rules that or a couple of services you can't use. I think there's FaceTime Live. You cannot use that to do a telehealth visit, and Twitch, and there's one other that I don't remember, but you can't be using those. Also, if it says you have to have an established relationship, you can now use telehealth with new patients as well. So those are some really key. They're really expanding the reach of telehealth during this COVID-19 pandemic. Also, if you have, it's something called the Ryan-Haight Act, which says you have to have an established relationship in order to prescribe narcotics. That they're doing away with that until the PHE is over as well. So if you've got opioid patients, if you're doing behavioral health with them and you need to prescribe something like that, you can do that. Just check your state laws very closely on something like that. You want to follow each one of those very, very closely, because there's very serious consequences for that. Some more flexibility. There's all sorts of waivers. CMS just came out with a waiver document a couple of days ago. I think it's maybe 31 pages long of different waivers that are out there. So whenever you do a telehealth visit, you do have to get consent to treat, just like you would with anything. But that consent to treat can be done over the phone. You want to record that in your medical record, and so also there's certain. I mean, the waivers now is you can actually do telehealth. Basically, it's not really telehealth, but it's the same thing as telehealth. Is when somebody comes in the emergency room, if you want to protect your providers, they can actually see that patient from home, and you will get paid as if it was done in that emergency room or in that nursing home. That way, you're not burning up PPE. You're not subjecting to your providers, which a lot of them are older, to getting COVID-19. So a lot of great waivers out there. You want to look at those very closely. Why Medicare patients been slow to adopt telemedicine? Probably because we're Medicare patients, and it's very hard. So again, the old wag the tail, the tail wagging the dog analogy comes to mind there. Medicare has fallen way behind everybody else. Medicaid has actually done a great job of getting out front. I know some states, especially I know Kentucky's been very good about setting up their Medicaid programs to pay the RHC rate. And then here are the reasons why RHCs, why telehealth has grown very slowly in rural health clinics. First off, the originating site. You had to be in an originating site, and I'll show you the slide on that one. Next one. And then RHCs could not be a distant site, meaning they're the provider of the telehealth services in the past. Now that changed on March the 27th. However, we still don't have the rules yet. That's why I'm talking about Medicare Part B, fee-for-service today, not rural health clinics. And then telehealth costs are not an allowable expense in order to compute the all-inclusive rate as well. Another reason why rural health clinics haven't really grown as quickly as started telehealth as some of the other types of entities. Finally, we're going to talk about what the originating site is. Before the PHE came about, you had to provide telehealth services in very limited areas. Had to be in rural areas, and it had to be, you had to go look up in this where it says Medicare Telehealth Payment Eligibility Analyzer. There were only certain zip codes or certain areas, even in the rural areas. Urban areas, it was completely off limits too. So, the patient had to come to an originating site in order for that. So they couldn't do it from their home. So this was waived during the period of the duration of the national emergency. So now I'm in Chattanooga, I can do, if I was a Medicare patient, which I'm not quite yet, but I could do telehealth in Chattanooga. If I'm in New York City, I can do telehealth. Before, it was off limits to them. Here's the listing of the originating sites. In the past, I would have had to drive from my home to my rural health clinic, and then they would have done originating site visit there that would have brought me to maybe my cardiologist here in Chattanooga. He would have been the distant site provider. He would have gotten paid his facility rate. He wouldn't have gotten paid his full amount he would normally get if I would have gone into the office and seen him, but he would have gotten paid something about 70% of what he normally would. The RHC would have gotten paid about $25 as an originating site. That rule has been waived during this period of this national emergency. Also, on March the 22nd, this FAQ came out about provider enrollment, saying that if your provider is doing telehealth from their home, then you're going to need to call. There's a hotline number that they have to enroll with Medicare Part B and put that address in there. That is gone away. It came and it went. It was gone as fast as it came. So you do not have to do that. So if your providers want to work from home, that's perfectly fine. You go ahead and you don't have to enroll them, do any type of special Medicare Part B fee-for-service enrollment for them. And that's confusing because they told us initially that you had to, and then they immediately backed off of that. Okay, virtual care, it definitely is. Somebody asks us all the time, is telehealth here to stay? Absolutely. So you want to, when you're developing your systems there, try to develop systems that you think will last. I mean, I know there's a lot of free services out there that you can use, but with most free services, there's a lot of things that you really need. You know, they give you the sort of the clunker version of it, and if the stuff you really need comes in a little bit later, you have to pay for it. So try to build a system. I know Azalea Health, which is one of our sponsors, they have a really good telehealth platform that you may want to look into that, and talk Clark or Davis about that, and that would be something you definitely want to do. RHCs, we typically get our money from Medicare Part A. It's, even though technically it's really not from Part A, but we're paid under a Part A cost-based reimbursement system where we bill on a UBO for if you have private practice time, or what we call non RHC time, or if you're doing fee-for-service and not a rural health clinic, then you're going to be billed a Medicare Part B. And I need to change my slide over. So I saw an error in my slide there. Of course, it says provider working from home. The new rules will change that. So I'm going to remove that provider working from home the next time I do this slide, because we want to change that. What is the difference between telehealth and telemedicine? Telehealth is basically just a big umbrella that telemedicine comes under. Telemedicine refers to providing the clinical services to the patients. And then we'll also talk about synchronous telehealth. That's when think about being in sync. There's two people, one person's on the phone, one person's on the computer, and the other person, think about all these Zoom meetings that you guys are having. That is synchronous telehealth. There's something called asynchronous telehealth as well, though. That's what we call store and forward. I have this little thing called Title Care where I've got a bad heart. So it has a little thing there, and it will actually take my heart readings, and I can store and forward those and send those to my cardiologist. And he's like, Mark, you're fine. And thank the Lord, I've been fine for over 2 years now. So that is really, really good. That's called asynchronous telehealth or remote monitoring. We won't talk about remote monitoring. There's a lot of money involved in that, but we have a lady, Miss Britton from Connect for Health, and she's going to do a webinar with us coming up about remote monitoring. Hopefully we can get RHCs to be able to do that. So let's go into how to bill telehealth to Medicare Part B fee-for-service here. And so we're talking about fee-for-service clinics, non-rural health clinic times, and I got to remove my provider home from there because that's not federally account anymore. And then this is something that just came out the other day. This is dated March the 30th. All the different waivers that are out there. And this basically, there was a law that's called an interim final rule that was actually published on March the 30th. And it really expanded telehealth dramatically. And so this is just a summary of some of the things that it did. Removing the frequencies. There were frequency limitations on telehealth before this. That removed those frequency limitations. It made remote monitoring easier for people to do. Again, rural health clinics can't really do remote monitoring as of right now, so hopefully that will change in the near future. It added people like licensed clinical social workers, clinical psychologists, physical therapists, occupational therapists, to where they can do these e-visits as well. So keep that in mind. It really broadened that. Also, it made it to where you can have telephone visits for our physicians. In the past, telehealth has always been defined as basically synchronous technology, and you had to have a video component to it. So the audio and video together in order for it to be considered telehealth, in order for you to be considered to get your normal reimbursement rates. They've added some codes on there. They don't pay fully like you would have received, but they are some telephone only rates that are available now. So keep that in mind. And then physician supervision requirements have actually, there's this thing called Incident 2 rules in Medicare Part B billing and in rural health clinic billing. And right now, those services can be done virtually. But for the physician, if you had to have, I think it's called direct supervision, if you had to be physically on site within like 30 seconds there, now you can do that virtually as long as you can sort of get in touch with them virtually within about 30 to 45 seconds via technology, which you can, then you can be supervised virtually going forward until the PHE is over. So remember, all these rules, or most of these rules I'm talking about, are going to be over with as soon as this public health emergency is over. CMS published a webinar, a video the other day. It's about 17 minutes long about how to bill, April the 3rd. As soon as the thing was released, it was almost out of date. But for the most part, it's still 96% accurate. So you definitely want to watch this one over and over. I've watched it a few times as I've prepared for this, and it's pretty good. It's very, very good. It's pretty boring, pretty dry, but it's pretty good. Now there's 4 types of virtual services that can be provided. Before March the 30th, there were only 3. So now we have Medicare telehealth visits. That's what we said before. That's video and telephone. Virtual check-ins, which is basically just a quick phone call, and we'll describe what else involved in that. And there's e-visits. E-visits are computer only. They're portals. They're people that ask you medical questions through a portal, and then you respond, and you keep up with your time during a 7-day period of time. And then once you get your 7-day period of time up, you see how many minutes you have, and then you bill a code for that. And then telephone services are sort of like a virtual check-in, except for they're a little bit longer. Virtual check-ins are about 5 minutes. You get to hit 5 minutes of time, and pretty quick. But then the telephone services are actually can be longer than that. They have different codes for the amount of time that you spend with them. And the longer you spend, obviously, the more Medicare will pay you. Those are new codes that they've added from March the 30th. So here is that document, that table that I showed you earlier that said was out of date here, and talks about Medicare telehealth visits. They've actually added 85 new codes starting March the 30th, and then these telephone visits we talked about there, they added six new codes for that. Those 6 are a part of that 85 new code. Well, actually, no, I don't think they are. I don't think they are. But that would be total 91 codes. So new patients can now be seen during the public health emergency for virtual check-ins and for e-visits as well. So keep that in mind. Those are some of the changes there. Here are the 4 categories of telemedicine that we have there. Telehealth, again, audio and video. Virtual check-ins, those are phone calls. E-visits, that's your patient portal. And then your telephone visits, those are your prolonged visits there. And we have certain HCPCS codes for each one of these. Most of these rules are pretty much the same on there, so I won't go through each one of those. We'll go in each one of these boxes a little bit more detail as we go through this webinar. I just don't want to spend too much time. Once we sort of got everything figured out, we said, oh, it's a place of service too, and you bill it, and it's really, you do what you normally would do. You do a 99213, you put an 02 on it, and you bill it. And it's once we got that figured out, Medicare changed everything on us again. So they actually released some new rules about that. So we'll go through what those new rules are for billing. So what are telehealth services, or who can provide those initially? And this is actually from that webinar they released on April the 3rd. Again, it's out of service. It's out of date already because they've added physical therapists, occupational therapists, and speech language pathologists to the listing of people that are eligible providers to provide telehealth type services. So there's your listing of people that can provide those services. And then they basically had 2 categories of new codes that they added March the 30th. And again, they went back to March the 1st. So you go back in time again, and we've been telling people for a while now, keep up with their services because there may be a way to bill it. And sure enough, go back and look at what you've done through March the 1st. If you got good records, then there's ability to bill for some of these services. So category 1, things that were similar to what they were doing before, they just added more to those. And then category 2 types of services where things weren't similar, but they came up with some new ways to provide telehealth services to patients. So keep that in mind. Here is the listing of the telehealth services with the new effective date of March the 1st, 2020. It is an Excel spreadsheet. If you click down here on this hyperlink, it will take you to that Excel spreadsheet. Here is what it looks like. There's 85 of these codes that say temporary addition for the PHE for the COVID-19 pandemic. Those are temporary codes that will end once the pandemic, the public health emergency is over. And then billing for a distant site. How you bill for claims here. This is something that came out of MedLearn Matters, and then about 2 or 3 days later, they actually had to change the I don't know if it's a MedLearn Matters or a Medicare MLN Connects, but it came out. Remember, I was telling you everybody was coding with you should have been coding with an 02 before. Medicare changed that. They said, nope, don't do that anymore. Bill telehealth services as if it was done in location where it would normally be. If that physician is at their house and they would have normally seen me as a patient in their office, and their office code is 11, then you're going to use the place of service 11, and they're going to put a modifier 95 on it, and Medicare is going to pay them their full fee schedule if they do that. If the physician is nice or he doesn't really know, and he just still puts the service code, the place of service 02 on there, Medicare is going to pay you a facility only fee. We'll show you how that impacts you just in a minute here. So let's go here. So number one is, and when these things are in yellow here, these are the things I've just copied and pasted from the CMS video that they did. So that's where we're getting our source of our information. So how does a qualified provider bill for telehealth services during the PHE? Place of service equal to what it would have been in the absence of a PHE. So again, if you do it in the clinic, it's going to be 11. If you do it maybe in a hospital-based clinic, I think it's 22 for that. Include modifier 95. So what we've just told you, that's how you're going to do that. And then this is straight from the page 15 of the final regulation. And I do recommend going back and reading that. It's 221 pages long, but probably the first 50 pages or so relate to telehealth. And it's actually very, very readable for that. So I definitely recommend going back and reading that. So, and it goes into the rationale for why they're making this change from moving away from the place of service 02 to the place of service 11. Okay, and this just sort of summarizes what happens. Pre-COVID, February 28, 2020, and before, you'd be using a place of service 02, the payment would be limited to the facility fee payment schedule. During the period of the PHE, from March 1st, 2020 to the end of the PHE, you're going to use place of service 11, and you're going to use modifier 95, and the payment will be at the non-facility fee rate. And again, there's no originating site restrictions effective March the 6th, 2020. Very important. So how much does Medicare pay for telehealth services? Let's take a quick look at this here, and you can see how important this place of service 02 means if you get it wrong. If we use place of service 11, modifier 95 on there, and we do a 99213, Medicare is going to pay you guys $76.15. If we use place of service 02 with the modifier 95 on there, they're going to pay you $52.33. You can see that every time you use the place of service 02, you get basically a 27% haircut when you do that. So you want to make sure you're using the proper place of service, using this March 30 Telehealth Medicare Part B Billing guidelines. It's going to be very important that you do that. Yeah, there's certain situations, if you were in the hospital, Medicare wasn't going to pay you additional facility fee or non-facility fee anyway, because you weren't using your clinic's resources to do that. So that won't have any effect in that particular case. If you're doing something in the hospital there, or some of the other services like that, there'll be no change in the amount of money that you receive. So let's look at how you were paid pre-COVID. I was a distant site provider. I was located in Chattanooga, and my patient is located in Dayton, Tennessee, which is in a rural area. They have a rural health clinic there, so they're the originating site. They're going to get paid $26 for it. Our physician who's here in Chattanooga is going to get paid $53.33, and Medicare spends $79.48. Now, in the PHE, we have our provider who's in a is in the Medicare Part B, is in a clinic. They're going to use place of service 11. Even if they're in their home, they'll use modifier 95. Medicare is going to pay that patient $76.15. Our patient is going to be in their home. So that's going to be, so there's not going to be any originating fee. So the Medicare funds actually going to save a little money here. They're going to pay $76.15, and our previous slide, $79.48. So that's the way the payment is worked. Remember, you can still use 02, but it would not be the smartest thing you've ever done to continue using that. So make sure you make that change in your systems. Modifiers used in telehealth billing. There's a 95, that's one that you definitely want to keep your mind on now, because you're going to have to add this in order to get paid right. If you're a CAW method 2, there's a GT modifier So if you're call, you want to know, you want to be aware of that. If you're in Hawaii or in Alaska, there's a GQ. I wish I was in Hawaii right now, but a GQ modifier. If you're in, there's a demonstration project for acute stroke. That's a G0 code there, and so if you're in that demonstration project. Also, GY, if for an ABN, if you want to try, and I don't recommend people doing this, is give the patient an ABN and say it's not covered, it's excluded from benefits, and try to get a denial that way. It's I don't know, that seems sketchy to me. I don't think I would use that. There is no GT modifier for Medicare as of right now. They pulled that one a few years ago. At one time, you had to use a GT modifier. So if you see that, that's one of the things that was outdated a couple years ago, but we still have people who want to try to put that on there. They took one modifier away, so what do you think they need to do? Well, they need to add another modifier, of course. And this is not just for telehealth, but last week, CMS announced a CS modifier. And a CS modifier, if you're providing services, and this starts on March the 18th, 2020, and it'll end to the end of the PHE, if it's related to the administration of a COVID-19 test, or if it relates to you trying to diagnose whether somebody has COVID-19 or not, then what will happen is if you put that CS modifier on there, that will waive the copay from the patient. The patient won't have a copay responsibility for that. And when Medicare pays you, instead of paying 80% of what they normally pay, they would pay you 100%. So you want to remember to put that CS modifier on there if you're ruling out COVID, or if you're treating a potential COVID patient, and there's in your medical evaluation is that it was related to COVID or trying to rule it out. That's when you're going to use CS. You're not going to use it for all patients, but you're going to use it for those COVID-19 patients. And then here's this will apply to rural health clinics as well. So you want to, when you're filing your claims as a rural health clinic, you're going to put a HCPCS code of 99213. So say if it's in the office, it's nothing to do with telehealth, you'd use a 99213. You would also use a CG modifier on there for our rural health clinics, and then you would add another CS modifier. And I got that from CMS from Baltimore this week. I've had an email stating that's the way you're supposed to do that. So that was good. And then here's just give you a little bit of when, where, what, how, and a reference on how to, on your CS modifier. Again, the time frame related March 18th, 2020, and it goes to the end of the PHE. If you already submitted claims before March 18th, you can go in there and append those claims. If you're a rural health clinic, there's a bill type, and I think it's 717, maybe 717 bill type, where you can go in. You have to have the document control number and go in and add that CS modifier to that. And that way the copay will be waived and you'll get your full RHC reimbursement rate instead of 80%. And then where, again, it applies pretty much everywhere, not just telehealth, not just RHCs, but in the healthcare field in general. What does it do? It waives the cost sharing portion on the Medicare Part B copays and deductibles for the Medicare patients. So that's good. So, and again, we talked about refiling and appending claims, and then there's your reference document there, where if you want to click into that, you'll be able to go and it describes what's going on there. Again, there's another reference document there. This basically, remember, this was announced 4/17. There's almost a month there of claims that could have gotten out without that CS modifier. So you want to take a look about going back and modifying and appending those claims, because it goes back to March 18th, 2020. Okay, that looks like me the whole time. I don't know how that's fine. Got still in there. Virtual check-ins. Here's what a virtual check-in is. Basically, it's a very short phone call, and it's from a 7-day. It can be related to anything that occurred 7 days prior, and it cannot lead to an office visit within the next 24 hours or the next available patient. Before, it was only established patients. Now it can be for new patients as well. So that is a virtual visit. It has to be at least 5 minutes of communication and technology time. So typically, it's going to be a phone call. A lot of times, sometimes there's store and forward technology where the patient takes a picture and sends it to you, and you look at it and you say, you know, well, yeah, you definitely need to come in, Mark, or no, just watch it for a few days and you will be fine. So that's what that. Here are the different codes for this. The G0010. This is for Medicare Part B purposes. Remember, we're not talking RHC right now. We're talking Medicare Part B fee for service. This is store and forward. This is taking a picture. This is me doing my heart and sending it to the doctor, and he looks at it real quick and says, yep, everything's good. That's $12.24 for 5 to 10 minutes. The G2012, again, 5 to 10 minutes, Medicare is going to pay $14.80 for that. And they use 7-day periods of time there. So they look at a period of a 7-day window, and during that 7-day window, you need to get at least 5 minutes of time in order for you to start billing. And remember to timestamp all of your telemedicine stuff or your telehealth stuff, because all these codes are driven on time. So you want to do that. So virtual check-ins no longer limited to rural settings. Patient must agree to the service, again, do a verbal consent to treat with them. You probably want to develop a consent to treat that you can get to them electronically and have them sign it. There's your 2 HCPCS codes, and then again, there's a broad range of communication methods that you can use to do that. They can take a picture, they can store and forward with a title care like I have, or you can call them on the phone. And then here is addition to the licensed social workers, clinical psychologists, physical therapists. They can now do these virtual check-ins as well. That was just approved the other day as well. So here's the timeline of a Medicare virtual visit. Our visit occurs today. We look back 7 days. Was our phone call related to something that occurred within the previous 7 days where we had a medical visit for that? If it's not, then are we going to have a visit within the next 24 hours or the next available appointment? If either one of those takes place, then you cannot bill the virtual visit. It's just a part of the visit that you've already incurred. So you want to keep that in mind, is every 5-minute phone call you have with the patient is not going to result in you billing a virtual visit, because either it could be related to something from a visit that occurred within 7 days, or you're telling the patient, come in the next day and we'll see you. That would not be a billable service. Here's your e-visits. Won't be a whole lot of, this is basically using a portal. Most of our RHC clients don't really have a whole lot of portals going on at this point, but you basically, a patient will go through the portal, ask you a question, you would respond to it, you keep up your time over a 7-day period of time, and then once you have so many minutes built up into that, then you could bill one of these e-visit codes here. So here's your codes, 99421. That's 5 to 10 minutes. You're going to get paid $16, $15.52 for that. A 99422, that's 11 to 20 minutes. You get $31.04, and then a 99423, 21 minutes plus, you're going to get $50. Remember, keep up with your time, and it's over a 7-day period of time. And then there's the document where we pulled that information as well. Here is some of the information that you need in order to do a digital evaluation. A lot of the same stuff that we've talked about before. You know, remember, let's see, was it HIPAA compliant format? And believe me, you probably want to go ahead and get a HIPAA compliant format, because that's them not being, what was the word I'm looking for? Them not looking for you doing something wrong. It's only going to occur during this PHE. Once it's over with, if you have a HIPAA violation, those are extremely expensive. So you probably want to just practice good HIPAA etiquette from the very beginning on that, and then waive for established patients as well during the PHE. So those are the requirements there. A lot of stuff I'm going to give you just to read, but otherwise this webinar would last too long and you probably wouldn't want to hang with it there. But there's how you keep up with your cumulative time. Again, we talked about the 7-day period of time. I'll try to move a little faster too, because I know we're dragging we're dragging along here. Here's some more e-visit takeaways for that. There's the different HCPCS codes. Also, co-insurances and deductibles generally apply unless it's related to COVID-19. Then you can use a CS modifier for that as well. And then here's digital online services, 99421. Again, what we just talked about there. But do remember, this is not for clinical staff time. This is just for clinicians. So if you're having nurses answer things for you and type of stuff in and all that, that time is not going to count. It's going to be when the provider is actually doing that time. Here is the new one, this fourth category called telephone services. There are the new codes that they've established for those, 99441 through 99443, 98966 through 98968. And one of those is for your clinical psychologist, for your physical therapist, and your OT. So here's the ones for the physicians and for our nurse practitioners and PAs. That's your 99441s, 99442s, and 99443s. And the first one is between 5 and 10 minutes. The second one is 20 minutes, or I'm sorry, 11 to 20 minutes. And the third one is 21 to 30 minutes. This is telephone time with the patient. So you will get higher rates. I couldn't find the rates. I looked for them. I think it's these codes are relatively new, and there's not any money attached to them at this point. So you may want to hold off on billing them until they're built into the system there. And then there are the codes for the qualified non-physician health professionals. Again, those are those new ones that they added there, your PT, speech therapist, and your OT people as well. They would be using those codes. I don't think we have a whole lot of rural health clinics that would use these codes. If you are one of those three provider types, you're gonna have to add another modifier for. So it's a GO, I think it's a GO, a GP, or a GN. So if you're one of those provider types and you're trying to bill, make sure you add this modifier on there. And so let's see here. Should on-site visits conducted via video or through a window in the clinic suite be reported as a telehealth service? The answer to that is no. Even though a lot of our providers are doing, especially if you're in nursing homes or if you're in hospitals, emergency rooms, they could be in the hospital somewhere on that campus, and the patient would be in the emergency room, and they would be somewhere else on the campus. That's not considered a telehealth visit because they're in the same location, but you will get paid the same thing as if you were physically, if you'd walked over, the across campus and was in the emergency room when you saw that patient versus seeing them via telehealth in your computer, in your office, wherever you are. Documenting a telehealth visit, and this will be the very end of the presentation. Thank goodness. Documentation of your telehealth visit. Did the patient consent for the via telehealth? Did you tell them about the HIPAA compliance? Do record the time that you started and ended, because it is time. Do not record the session. That's one thing that your lawyers will tell you is don't record these from a legal standpoint. That's probably not a good thing to do. Ask for consent to treat verbally and document that in your medical record. Do ask for vital signs. There's a lot of things that people can do, getting their temperature, getting their weight. A lot of people have blood pressure cuffs. There are ways to get that. Some people have the title care thing that I have. You can do things like that. And then note the provider location where you're located and where the patient is located as well. That's going to help you to bill it correctly. For RHCs, we're still waiting on RHC telehealth guidance. It's been 2 weeks since March 27th. We're still waiting on the information for that. As soon as it comes out, got a bunch of great speakers lined up, and we'll go over the Medicare Part A RHC piece of that. But I knew the Part B stuff was going to take way too long. My slide presentations got up to like 200 slides, and I was like, oh my goodness, there's no way we're going to get through all this. So I didn't want to take away from Charles James' time or some of our other speakers. So thank you for listening to this very, very long pop-up webinar, and we will we will see you when we do the real webinar with all our great speakers and all our great friends once we get the new regulations out. Have a happy Easter. Be safe. Thank you guys for all that you guys do. You're our heroes, and we appreciate you very much. So I'm going to stop the webinar now, and we certainly do appreciate everybody. Thank you.